Good day, my dear postgraduate students. Welcome to the continuation of recent Advances-25. The topic for the day is Neuroendocrine Neoplasia. These are the authors. I start with a line diagram, a fantastic picture again picked up from the net, and this is the reference for it. The neuroendocrine cells are scattered cells which are found in the various layers of the GAT and elsewhere. And they might cluster together to form a so-called neuroendocrine tumor. And this incidentally is a picture of the appendix. That is why we do sample the tip of the appendix as a routine. It will not be difficult to draw pictures like this, provided you have some inclination. Even this appears to be quite simple, as I saw it in the net. Now, going to neuroendocrine neoplasia. The definition is, we'll start with the second line first. By the diffuse and consistent expression in the neoplastic cells of the neoplastic markers. So these are being continuously expressed or produced. So neuroendocrine neoplasia is defined as the characteristic histological and ultrastructural features of the cells which consistently produce these markers. The expression of the biochemical markers reflects the presence of the biosynthesis and the storage of these elements. So much so, more than the physical presence, its physiological presence might lead to a great havoc. This is just for a recall. Not uncommonly, we do get neoplasms as these in the GAT. Some of my pictures will be just a recapitulation so that the topic becomes a little easier. I find that there are yellowish nodules, the characteristic color of a carcinoid tumor. And the mucosa is intact. There can be a protrusion of the mucosa in a pseudopolypoid manner. So this can be in the GAT. Elsewhere, in the lung, etc., again it can form a solid nodule thanks to web pathology and basic medical pathology. Well circumscribed lesions. And there used to be the earlier terms such as the argentaphine cells and the argyrophil cells, the silver or the gold that is being stained upon. Apodomas are amide precursor uptake and decarboxylation tumors. These are now slowly out of vogue, and the term neuroendocrine has crept into practice. I do not know how long it will stay, but then for the time being, it will better that we merge the old with the modern in an imperceptible manner. More important will be the clinical presentation. Now, what are the recent terms? The recent terms include neuroendocrine neoplasia. Then there is something called as neuroendocrine tumor also. And finally, a neuroendocrine carcinoma. I was wondering what the difference between these three is. After all, they all appear to be meaning the same. But then the author very deftly marks it as well differentiated and poorly differentiated in favor of neuroendocrine tumor and neuroendocrine carcinoma, respectively. And behind me, you will be finding some quote which we shall unravel shortly. Also, you find that there will be large cells as well as small cells of neuroendocrine carcinoma. Sometimes there can be mixed cells of neuroendocrine neoplasia. So these are the various terminologies. Always, I found this topic a little out of reach because the terminologies were not as the very common ones that we usually use in day-to-day reporting. But then this we shall have in our mind: the large cell, the small cell, and the mixed cell. Also, the poorly differentiated. How do you demarcate the poorly differentiated? The cells will be atypical. They have a large nuclei, variable amount of cytoplasm. And sometimes the small cells can be having crushing and molding of the nuclei. A crush artifact is in fact one of the diagnostic features of a neuroendocrine neoplasia or a small cell carcinoma of the lung. Predominantly, you find that it can be either a small cell or a large cell or a combination of these. The large cell tumors have got some kind of a geographic pattern. The patterns of this tumor I shall be telling you people shortly. Geographic is nothing but a map like irregular outline, the periphery of which might be showing solid islands which are infiltrating into the surrounding tissue. So these are the features in general of the atypical or the poorly differentiated neoplasm. And the entire stretch is the recent terms. Kindly become familiar with it. This is again a superb picture which is worth its weight in gold. Now the topic that is given is epithelial neuroendocrine neoplasia. Then what is non-epithelial? This diagram very strictly marks it. The non-epithelial will be something related to the adrenal, the bladder, the pheochromocytoma, and the para-aortic neoplasms. Whereas the epithelial can be from the pituitary, thyroid, and parathyroid, the endocrine organs on one side, or the diffuse neuroendocrine cells as can be seen in the lung, the breast, pancreas, GIT, genitourinary, and skin. In short, if this question is asked, you will be able to enumerate what are the sites it occurs in. Simple. And again, a fantastic diagram. A little picture is worth a million words. Incidentally, I always say this: go to playlist. It will give you a complete list of the topics in an orderly manner. I am not interested in the diagnosis. But what am I saying in this? My professor used to say, it has got a characteristic pattern, an organoid pattern, that is very typical of an endocrine tissue. Endocrine tissue, if you see one part of it, there is no necessity for you to see the remaining part. They will be absolutely symmetrical or repetitive of each other. That is what we are seeing. I am finding some kind of a glandular or a ribbon-like pattern, and the cells are all more or less uniform. And they do resemble an endocrine organ. That is why a carcinoid, it has got an organoid type in which there are no ducts, no delivery system, and the substances are being directly delivered to the blood. So please have this in mind. This picture is only to show you the repetitiveness of the pattern. This is again a fantastic picture. Touch wood. How I got into it, I do not know. But then it took me more than a week to prepare for this particular topic. There are the epithelial and the non-epithelial neuroendocrine neoplasia. After all, what is this topic about? Epithelial neuroendocrine cells. So the neuroendocrine cells the author divides here in this article is epithelial neuroendocrine and the paraganglion cells. We had already seen this in a diagrammatic form earlier. But then this epithelial neuroendocrine itself is divided into its origin in various organs such as the pituitary, parathyroid, thyroid, the C cells, airways, GAT, genitourinary, breast, skin, etc. And some of them are again being redivided. For example, the gastrointestinal and the pancreas. You have got the cells starting from A to L and PP cells. Similarly, the pituitary. You have got the different lineages of cells. And sometimes these are again being divided into according to the substances that they produce, somatotrophs or the others, corticotrophs. So this is a very fantastic sketch. It gives us an idea. In one glimpse, I will be able to recall that there is an epithelial component and a neuroepithelial or a non-epithelial component. And secondly, if I find that there is a plethora of tissue where there can be the epithelial component, and they themselves can be having multiple divisions depending on the substance that they elaborate. Go back to the initial definition. It is mainly based on the substance that is being elaborated by them. Again, an incidental one. It is supposed to be a retroperitoneum. The credit goes to these authors. I find that the lesion is well circumscribed. It has got a slightly dumbbell shape over here, which is possible even in the GH. Though in this case, I think it is a retroperitoneum. Fine. And I find that there is a pseudocapsule. It is smooth. The cut surface also invariably will be solid and homogeneous, yellowish, unless there is a necrotic degeneration. There are certain transcription factors. This, for heaven's sake, kindly buy it. There is no other way. There is no logic to it in the present world today. There is an upstream protein control gene. And then there is a thyroid transcription factor 1 for the thyroid and 1. There is an insulinoma 1. INSM 1 means insulinoma 1, which is a second generation of neuroendocrine marker. And there is also called as cluster of differentiation, NCAM, neural cell adhesion molecule, and NCE, they say it is obsolete nowadays, though it has been mentioned in some of the references. And SSTNR, somatostatin neuroendocrine receptor. So kindly have this so that you will be able to rattle off at least a few in the transcription factors which are essential in the diagnosis of the neuroendocrine neoplasia, be it epithelial or non-epithelial. Now, what are the cytological and the histological features of a neuroendocrine tumor? In this reference, the authors have given the features of well-differentiated and moderately differentiated tumor cells. They are medium in size, round to polygonal. Sometimes they can be spindle-shaped. They have a eosinophilic or an amphophilic cytoplasm. Amphophilic means it is a mixture of eosinophilic and basophilic. They are monomorphic, as I had mentioned earlier, with round to oval nuclei. And classical salt and pepper chromatin, you people will be very well aware of. The nucleoli are characteristically absent. No prominent nucleoli. Their size is less than 2 millimeters. And you find that they have got a low mitotic figure. So these are all the features. In fact, basically, if you can remember the features of a benign neoplasm, I think more or less it fits in. And then there are the various patterns, such as this: solid, islet, ribbon, trabecular, glandular, and there can be an admixture. If at all you get a slide like this in the exam, they will definitely ask you what are all the various patterns, what are all the various substances, and what are the syndromes that can be produced by it, so on and so forth. Organoid, as I had mentioned earlier. The stroma is very delicate, almost absent, maybe just present to support it. It is an expansile type of a group. And the infiltration is normal. If it is higher, then it is a higher grade of a tumor. The structure alone, however, is not a reliable feature. The behavior we cannot predict by means of the structure alone. So kindly read this up. So this is the background of my picture on the screen. Common sense is not so common. A beautiful quote. The authors again say the classifying principles as recommended by the WHO. Now, in any of these classifications, three things are essential. One, the morphology. Two, immunohistochemistry. And three, the molecular basis. Now, these three are imperceptible and they are mixed with each other. If you go to the recent WHO, you find all these are given. Nevertheless, this is important. A tumor can be a small cell or a large cell, and functional tumors are classified according to the hormones which are being produced by them. Sometimes they can be dichromatic in the sense there can be a mixture of two. There can be two types, and always the morphological differences underpin the molecular and cancer driven genes. So always it is the morphology that is essential first. We will have to make a histological diagnosis. And when they become too very poorly differentiated, they cannot have the adequate exposure or the markers. And secondly, you find that there can be the cancer gene changes also. So they cannot be used for diagnosis. The more differentiated they are, the better are these being expressed. So targeted therapy can be used when all of these are being well diagnosed and delivered. There are two regulatory pathways for this. One is this is an electron microscopic picture in which I am finding numerous dense core granules. And if you observe very carefully, there will be a kind of a network by which all this material are being conducted to the exterior. There can be the large dense core vesicles as well as the small synaptic vesicles. And the presence of these connotes a kind of neurological origin of these tumors. This is a particularly important and a simplified method of this grading. Grading and staging has been given, but I downloaded this particular one. I feel that this will be useful for us. Basically, they are divided into low grade, intermediate grade, and a high grade. And whatever be it, forget the different organs where they are. What is important will be the amount of mitosis. And secondly, whether there is the production of the key index, what it shows. And third one will be the areas of necrosis. These three are fundamental. And the rest of it, you people can read up. Mitotic activity, key 67 index, then there will be the areas of necrosis that is important. These are again the various markers. These are subject to changes as such. Nowadays, they say that neuron-specific chenolysis is not very much significant, whereas chromogranin, synaptophasin, they have stood the test of time. So, how do you confirm the epithelial origin? You find that these markers are essential for the epithelial origin. Neuroendocrine, by means of these, it can be done. And the grading and the staging, key 67 is most important. I think this alone will suffice for you to write a good answer. For the morphogenetic correlation, this word I myself coined, you find that there can be well differentiated, low mutational burden is there. That means it is both morphologically as well as genetically of better significance. Site-specific genetic epigenetic differences. In the foregut, MEN1 gene is important. In the pancreas, P10, TSC1, C2, and DEPT-C5. And telomere length maintenance is assessed by means of DAX and ATRX genes. NET and the NEX are important for the clinical and the epidemiological differences. So this is meant for the morphogenetic correlation. This particular one, already you people might be knowing, but again we can revise it a little bit, worth its weight. And now Coming to the topic per se, what are the current specific classifications? It appears very weird but not so difficult. He has mentioned a three-tiered classification. And in this, he has included the head, neck, and thorax. In the head, you have got the salivary glands, and then thorax, the organs can be the lung and the thymus. In all this, there have been specifications for the KI index, for the mitotic activity, and the presence or absence of necrosis. I would like you people to kindly go through it. Even otherwise, if you do mention these three parameters, it is more than enough. Based on this, they have differentiated into well differentiated, moderately differentiated, and poorly differentiated. Then there is a two-tier classification. Three-tier, it is used for the head and neck and for the thorax, whereas the two-tier, it is mainly used for the medullary carcinoma of the thyroid. Here again, it is divided into the low grade and the high grade based on the necrosis and the proliferation. This much, if you people can mention, is sufficient. Of course, these parameters are all constantly repetitive. Ka67 index, areas of necrosis, mitotic figures. And look at this one. Again, a typical pattern, an organoid pattern, very regular pattern. If the history is given, I would very well suspect it to be a medullary carcinoma. But then a follicular carcinoma can be a close differential diagnosis. And going to the cytoplasm, the cytology, you find that there are cells with eccentric nucleus. And then there can also be a crush that can be identified with it. If I look at the chromatin, there can be a salt and pepper type of chromatin which can be seen in some of the cells. So this is the difference that he makes. So this is the cytological picture, and this is taken from the Wikipedia itself. There is nothing but salt and pepper that has been added so that it is kept for comparison. Then there is a three-tiered digestive organs. So again, it is divided into well differentiated and poorly differentiated, and there are three grades of morphology. In this, only the Ki67 and the mitosis are included and not the areas of necrosis. So that is why it is very important. Even 2 days back, we made a classification, this one, diagnosis of a neuroendocrine neoplasm in the duodenum, but could not classify it further because of the limitations. Necrosis is not considered to be a feature, and this is the reference for this one. This incidentally is again taken from this. I find that there is a projectile lesion, there is a mucosa. Mucosa can be stretched, but invariably it is not ulcerated. And yellowish tinges classical of this. One of the complications and the presentation of this can be an intersusception. So there is a consistent peristalsis, as a result of which the proximal lobe goes over the distal lobe, producing an intersusception. An obstruction can be one of the features. Second one can be any of the carcinoid symptoms. So this again, there is a synchronous gastrointestinal carcinoid tumor and an adenocarcinoma. So this is one that has been diagnosed, well differentiated neuroendocrine tumor, and this is a moderately differentiated adenocarcinoma thanks to this reference. See how dangerous pathology is. The carcinoid tumor, again, this is the reference. This is showing the small of the large vesicles. You find that all of these are secreting abundant material which are being liberated by means of a canalicular system. This again is a carcinoid tumor over here. It is projecting. So it is a button-like thing, and as a result of which there can be a nilly. This is what is shown over here. So a classical presentation. You do not get an ulcer as such, but then over a period of time, it can be present. There are various patterns shown, that is, it can be nodular, solid, insular, trabecular, or in ribbons, tubules or glands, rosettes, etc. They may be poorly differentiated or well differentiated, sometimes atypical, and mixed patterns also can be possible. Synaptophysin of the ileum. This is the one. And this incidentally is the reference for the next one. I would like you people to kindly see this. This is again a very superb picture of the mixed epithelial endocrine neoplasia mean. And this is a flow diagram wherein it has been divided into the composite, collision, and the amphicrine. So I would like you people to kindly go through it. It is worth its weight in gold. So there can be the high grade mean, then an intermediate grade mean, low grade mean. And what are all the tumors? There can be an adenocarcinoma, neuroendocrine tumor, again an adenocarcinoma, neuroendocrine tumor in each of these categories. So you find an adenocarcinoma, etc., can come under the epithelial. This will be an endocrine component or a neuroendocrine. So this I would like you people to remember. What is a mixed epithelial endocrine neoplasia? Again, a wonderful flow diagram taken from WHO. These are the various histological patterns. I will not be reporting again. So you find that there is a carcinoid tumor, there are various patterns. This is obviously atypical. I am finding the large nuclei, there is a pleomorphism that has set in, and glandular area is there, but in some areas it is becoming solid. This is another version of it, the markers. Markers are substances that are being liberated into the serum. Serological markers are there. And this is a tumor over here, and what are the various substances that are being liberated by them. Parathyroid tumor, there is a parathormone. Neuroblastoma, neuron-specific enolins. Carcinoid tumor, there can be a 5-hydroxy-indolacetic acid. So on and so forth. I would like you people, it is again a recapitulation. It will be more useful for a carcinoid syndrome and so on. This again, at the ample of water, there is a neuroendocrine neoplasia. Kindly read the legend of it and the reference is given. This is a wonderful picture again. It is worth. Now you are having the neuroendocrine tumor morphology. So what else is it going to show us? Whether it is going to be no, then you'll have to consider the other differential diagnosis. If it is yes, then it can be a neuroendocrine differentiation. And whether it is going in for an epithelial differentiation or it is positive for chromogranin, synaptophysin negative, then it can be other differential diagnosis. Epithelial means there can be cytokeratins and paraganglioma, etc., can be considered, and genetic testing will be necessary for us to make a diagnosis. Quidnet and pednet. These are again important for the cytomorphology and the high proliferative index. If this is there, then the transcription factors will have to be studied. And if there is a low proliferative index, then you'll have to consider the site of origin. These are the things. This is the way it is being done. So sequentially, there is a yes, no at each stage, and you proceed. Ultimately, you are able to make a diagnosis as to what it is, whether it is duodenal, whether it is rectal, and what is the marker that is present. This kind of an analysis is mandatory. It is almost like a coagulation disorder. You try to rule out one by one and finally come to a diagnosis. This is an algorithm. So insulinome. I find that in small cell carcinoma, it can be positive for insulin marker. So this is just a difference between the neuroendocrine tumor and a neuroendocrine carcinoma. And the added diagnostic aids are chromogranin A and synaptophysin. So what is being studied is a morphology, then the positivity for these markers. So the references over here, I would like you people to kindly go through. So this is again the reference of it. The entire list is given. I would like you people to kindly go through this one. It is worth it. And you find that there is absence of necrosis, abundant cytoplasm, a low degree of atypia for the neuroendocrine tumor. Carcinoma will be having increase in all of those. So what are the diagnostic challenges? Diagnosis is usually straightforward. We can say that it is a neuroendocrine tumor. But the challenges will be in the correct diagnosis, the grading, and the biopsy material. Distinction between the high-grade neuroendocrine tumor and neuroendocrine cancer, carcinoma, is supposed to be difficult. Morphology is difficult to interpret. Other lesions may mimic, as we had seen earlier, and pathologists must be aware of mimicking lesions or collision lesions. And these are the various markers people should be aware of. Ancillary techniques are mandatory for NEN, Neuroendocrine Neoplasia. The key points are, in cytology, well-differentiated, monomorphic, low ATPR, and there is absence of cytoplasm of the tumor cells. Crush artifact must not be confused with poorly differentiated cells. And cytology of the poorly differentiated cells, there will be dirty smears, crushed cells will be present, and scanty cytoplasm or increased nuclear cytoplasmic ratio. The histology, there will be well-differentiated, can be expand cell forms with minimal necrosis. Poorly differentiated, increased necrosis, increased mitosis. Mimickers to be ruled out. And nowadays, all these are essential for platinum-contained chemotherapy. So this is one of the references. And finally, coming to all this, absolutely, classification is an aid to orderly thinking. Science is a systemic classification of experience. I have started with the original definition of a carcinoid, then a neuroendocrine tumor. What are Argentine cells? What are argyrophil cells? What are the various histological patterns that you people can see? What can be the gross patterns? What can be the clinical presentations? And then, what is a neuroendocrine tumor? What is epithelial? What is non-epithelial? And what are the sites where we can get all this? And how do you grade them into well-differentiated, moderate, or poorly differentiated? And what can be a collision lesion? What can be the mimickers? So you find that there's too large a list, but then science is a systemic classification of experience. I hope I had given you enough justice and you will be doing the answer well. Thank you.